Hello, in this video I'm going to be talking about all the genomic assays that are used in the care of people with breast cancer. Before I go on, I'd love to invite you to subscribe. We're always putting out new content, and don't forget to go to yerba.com to get your personalized report. So what are genomic assays? Why do we order them? What do they mean? How do we use them? And which one is right for you? So the first thing I'm going to do is make the distinction between genomic testing and genetic testing. Genomic testing, these are tests that we do on the tumor itself. So when you've had surgery for breast cancer or before you do, your tumor can be sent away for a specific test. And these are genomic assays where the tests look at the expression of different genes and proteins, and they look at the makeup of the tumor, the personality of the tumor, if you will. Genetic testing is done on a person, and this can be done by taking a swab from your cheek or a tube of blood, and that looks at the genes you inherited from your parents. So the genomic assays or tests are done on the tumor. Genetic testing is done on you, and they look for different things. Genomic assays look at how likely is that tumor to come back in the future, either in the breast or other parts of the body. And genetic testing tells us whether or not you inherited a susceptibility or a vulnerability to a cancer from a family member. And some of the mutations we have in our bodies can also just occur spontaneously. So they look for different things, and they're done different ways. Genomic testing, as I mentioned, is done on the tumor itself. This can be done on a tumor that's already been embedded in paraffin, so it doesn't have to be done on tissue that's just been removed. And they're usually sent away to a company, and the test can take a few days to a couple weeks to come back. Usually it's about 14 days before the results will come back. There's sometimes a little delay in confirming that your insurance will pay for it, and if it doesn't, arranging a payment plan. And that can take a few days, and then the tumor can be sent, and that adds a couple weeks. So if your tumor's been sent for one of these tests, it can take 2.5, even 3 weeks. It's sort of the extreme for your medical team and you to get the results of the test. Everything I'm going to say from this point on applies only if the tumor is HER2 negative. We don't yet do genomic assays in people whose tumors are HER2 positive. So I'm going to go through each of the tests right now, and if these haven't been done on your tumor, they could still be done on a surgical specimen, or perhaps this wasn't the right test for you. But I'm going to go through all of these, and then I'll say a word about some tests that are done and developed locally in the hospital or the practice where you get your care. We refer to those as homegrown tests, and I'll say a couple words about those as well. So the most common test, and the one that's been studied the most, is the Oncotype DX test. That's the brand name. And this looks for 21 genes. A couple of them are what we call housekeeping genes, just to make sure that the assay is working. So this looks at 21 genes, and it will come back with a score of low, moderate, or high. And if the score is low, it means there's little benefit from chemotherapy. If it comes back high, that indicates that there is benefit, measurable benefit from chemotherapy. If it's in the middle, it depends on your menopausal status, what the score is used for. So the range is a little bit different. I'm not mentioning that in the video because new studies come out and change the range, and I don't want to add confusion. But if you're in the middle, it depends, is it closer to low, closer to high, and what's your inclination in terms of chemotherapy or not? So for people who come back in the middle, smack dab in the middle, it's as if you didn't have the test at all. And this is where your preferences and your other medical problems can help play a big role in whether or not chemotherapy is offered to you. The next test I'm going to talk about is the EndoPredict test. That's a brand name as well. That's a trademark name, the EndoPredict. And this is an assay that looks at 10 genes. This test can be done in people who the tumors were node negative or 1 to 3 positive nodes, and the tumor is estrogen receptor positive. That's the same as the Oncotype DX, so the same patient group, and it looks at, instead of 21 genes, at 10 genes. That doesn't mean it's not equivalent, it's just how the score was developed. And as with the Oncotype score, it can help look at your risk of recurrence over the next 5 to 10 years. And it's not been as validated for whether or not there's a benefit from chemotherapy, but it can look at the risk of recurrence, and that can help people decide if they're going to receive chemotherapy or just endocrine therapy. The next test I'm going to talk about is the MammaPrint test or assay. The MammaPrint looks at 70 genes within the tumor, and it can help look at the risk of recurrence at 10 years, which is really what we want, right? We want 10 or more years, not just 5 years. And this can be done in people even if the tumor is estrogen receptor negative. So whether the tumor is estrogen receptor negative or positive, the MammaPrint test can be done. This test is widely used, though not as widely used as the Oncotype DX, and I would say many people are hesitant to use it to say somebody does not need chemotherapy, but it can be very informative in understanding the risk of the cancer coming back over the next 10 years. The next test I'd like to talk about is the Prosigna, and this is the last one in invasive cancer. This is made by another company. It looks at 50 genes. Tumors need to be either lymph node negative or just 1 to 3 positive nodes and hormone receptor positive. And this test can also look to see what the risk of recurrence is 10 years out from surgery. There's one other assay I'd like to talk about, and that's the Oncotype DX DCIS test. And this test has been looked at in people with non-invasive breast cancer or ductal carcinoma in situ, stage 0, to see if the risk of recurrence is low enough that radiation therapy could be omitted. A lot of these tests are still being studied, and the comfort within the oncology community and the radiation oncology community with these tests is growing with more and more time. As I mentioned, the test that's most established is the Oncotype DX recurrence score. So what about tests that are developed locally in the hospital where you're getting your care or in the laboratory, so-called homegrown tests? That's not meant to sound disparaging. These tests tend to try to replicate the tests that are done by commercial labs, by companies, and the hope is that it will save you a lot of money and save the health system a lot of money if you don't have insurance. These can be very appealing. It's harder for us to say with any confidence that these tests have the same value as the tests that have been validated in thousands and thousands of people with breast cancer. So I don't want to say that they're worthless, but it's much harder for your team to have confidence in these tests. And of course, all of the tests started out without data, but they weren't deployed or used until that data came back and was very firm, and physicians could be really confident in how to interpret those tests. The last test I want to talk about is the Breast Cancer Index. This is an interesting test that's used to see if people will benefit from more endocrine therapy after 5 years. So in people whose tumors are hormone receptor positive and whose tumors are, you're already at 5 years out, we can look at the original specimen and do the breast cancer index and see, are you one of those people who would benefit from more therapy? This is most useful in people with what we consider low-risk tumors, so a very small 1 centimeter lymph node negative tumor in whom we didn't originally give chemotherapy because the risk was really low. The breast cancer index can say whether or not that same person might benefit from 5 additional years of endocrine therapy. If you're somebody who is not going to take endocrine therapy at all and who's not going to take it beyond 5 years, this test won't be useful to you in that you've already made up your mind. if you're thinking about 5 more years and you want to know, is this going to benefit me, the breast cancer index can be helpful. So what's the benefit of genomic assays? Really, as you can tell from what I've said so far, they give you additional information to look at the benefit, the marginal benefit, or the added benefit of chemotherapy, for example, or more than 5 years of endocrine therapy, or in the case of ductal carcinoma in situ, how much benefit would somebody get from radiation therapy? So they're really used to help fine-tune treatment. So these tests are really used to fine-tune your treatment decisions and can give you a sense of your overall prognosis. I do want to say that they're still giving you a chance, a number that's a chance. So if we say the chance of the cancer coming back is 20% on the basis of one of these tests, you have to do the math and say that means the benefit of it, the likelihood of it not coming back is 80%. And we don't know in a given person, are they in that 20% or in that 80%? So this is where your preferences come into play, your comfort with risk, either risk of treatment or risk of not receiving the treatment, really needs to come into play. In the case of giving chemotherapy when there's no benefit, like a low-risk Oncotype score, giving chemotherapy, it's not really a preference at that point. At that point, you're going to get more harm because there's no benefit from chemotherapy. And so in people with a low Oncotype DX score, giving chemotherapy is not recommended. If you are not going to get chemotherapy no matter what, even if your score comes back high risk, we don't recommend getting this test because it's not influencing your treatment decision. Though there may be some added benefit of having that information that, for example, the cancer is very likely to come back without chemotherapy. Perhaps that's helpful to you, but most of the people that I've talked to about this have not found that helpful. So they're really more useful in making treatment decisions. Again, in a given person, you know, these statistics are not that useful because in your case, it's either going to come back or it's not, and knowing whether it's more likely not to come back is probably helpful for people. So let's say you fall into one of these categories and you're wondering which test is right for me. Well, the first thing I want to say is the practice where you're getting your care is most likely comfortable with one or maybe two of these tests. So they are really familiar with the data and the scores and what the scores mean and how that should impact your shared decision making. So, you know, ask your practice what's the test you're most comfortable with, because to be honest, it's probably the test that you want to have. It's always good for both you and your team to feel as comfortable as possible with the information. That doesn't mean that if you get one test done in one practice and then you receive your care in another practice, that the doctor can't adapt. So if you get a mammoprint in one place and then see a doctor who's more familiar with the Oncotype DX assay, that won't impair your care. Certainly we can handle all information no matter where it comes from. But if the tumor is lymph node negative or 1 to 3 lymph nodes and hormone receptor positive, the Oncotype DX score is going to be the most likely to be done. Mammoprint, Prosigna, EndoPredict are probably less likely to be done. Estrogen receptor negative tumors, the Mammoprint can be done, and that's the only test that can be done in tumors that are estrogen receptor negative. And then the only test in DCIS that's been studied and validated is the Oncotype DX DCIS score. I've covered a lot. I hope this is helpful. Don't forget, you can always put a question or comment below. It does take us 1 to 2 weeks to get back to everybody. We have a lot of comments and we also want to respond thoughtfully. So be patient and also please be kind. And thank you so much for watching.